Thank you so much for having me to speak about pharmacodynamic endpoints. So we heard about raising the bar. So can we start to define certain populations that we can choose to actually find out who will benefit from some of these new drugs and then be able to pick out those miracle populations where we have significant benefit? So what are pharmacodynamic endpoints? They are actually a number of different endpoints. And so they're measurements that you're actually hitting your target with the drug. So one of the questions that we answer with pharmacodynamic endpoints, particularly in the early development stage, in the phase 1 stages, are you actually hitting your target? Or are you hitting other targets? What's the dose and what's the schedule that you need to hit those targets effectively? And then what are the side effects? We'll show you some data about different toxicities that can actually show you PD endpoints. And then we can also use those pharmacodynamic endpoints to find new targets to hit. I'm going to show you some examples of those. But more importantly, can we use those endpoints to accelerate drug development? Can we faster determine the right dose, the right schedule, and then the right population who will have the highest likelihood of responding to those targeted agents? So here's some basic examples of pharmacodynamic endpoints. We have imaging endpoints, including PET scans and dynamic contrast imaging. We have blood, multiple different types of blood tests that we use: serum, plasma, peripheral cells, hair follicles, urine, skin, tumor. And I'm going to show you some examples of these, as well as toxicity. And that does project better. The rash, for instance, that's associated with EGFR inhibitors. So how are we incorporating pharmacodynamic endpoints into drug development? Well, again, like we mentioned, in the early phases of drug development, it gives us a clue as to whether or not we are hitting our intended target, and this is typically seen in the phase 1 studies, as well as proof of mechanism. So if we hit the target, do we actually do anything to attack the tumor? And this is also done in the phase 1 studies as well as dose expansion cohorts within phase 1 studies. We also do this within phase 2 studies. And then can we use those pharmacodynamic endpoint findings in a much larger population in the randomized phase 3 studies to really find out if those patients receive benefit? Now, this is all well and good, but we are also learning that we don't know as much as we think we did. There's a number of challenges that we have within pharmacodynamic endpoints. First of all, they're not really yes or no answers. So mutational status we're even seeing, we thought that was black and white and yes and no, but we're starting to learn now that it depends which mutation you have. We also know that they're more scalar variables. So we have, for instance, IHC staining. So it's not a yes or no. It's a 1+, a 2+, or a 3+. We also know that they're not exactly easy to obtain. We're now starting to have to do fresh tumor biopsies on our patients to try to get the most current data for pharmacodynamic endpoints. And I'm going to show you some data at the end of this talk where we're seeing that maybe even with fresh tumor biopsies, we're not capturing the entire picture. We're starting to develop surrogates, so we'll talk about using plasma samples as a surrogate for fresh tumor biopsy. There's also interpatient variability. So one patient may not have the same data as another patient, and then how do you reconcile the pharmacodynamic endpoint data that you get between patients? There's also reproducibility of results. So actually the assay, how reproducible is that assay? And I'm going to show you a little bit of data on sample handling and how that can change your readout for that pharmacodynamic endpoint with just the timing of when the biopsy is processed, for instance. Where's the source of the biomarkers? So people have been talking a lot about archived tumor versus fresh biopsy. Does treatment along the way change what that tumor shows you? Is a metastasis the same as a primary? Is one metastasis the same as another metastasis? And we're starting to learn that maybe not. And just because you're actually hitting the target doesn't necessarily mean that you're going to kill the tumor. So here's one example. This is post-surgical ischemia. Thank you to John Marshall for giving me this slide. And this is looking at phospho-mTOR staining. And you can see with time after you do that surgical biopsy, the intensity of the staining actually changes. So when you're flash freezing those samples, is it at 5 minutes, 10 minutes, 15 minutes? It's actually going to change your baseline measurement depending on when you froze that tumor. So there has to be consistency in when you're actually obtaining the tumor and when you're freezing the tumor. So what are we doing now within GI cancers for some of the pharmacodynamic endpoints? Well, first of all, we've seen some data with PET. We're using PET now to look at patients who have early response and those who do not have early response. So can we change their treatment faster? We're also using PET as a PD marker that we're hitting the Pi3 kinase pathway, a very hot target within multiple different tumor types. So this is some of the data with GIST. So we can see here that for patients who have an early response, an early decrease in SUV uptake after treatment with sunitinib, you can see that they have a much improved progression-free and overall survival, predicting early on who is going to do better with this treatment. We've also seen the Municon data where we've used this for patients with esophageal cancer, where we can see here with an early PET 2 weeks into treatment, whether you're a responder or non-responder and how you do. And you can see here, of course, that the patients who are early responders to treatment on PET tend to do better than those who did not. And you can see here in terms of survival, that is the same. So then can we use that to start to direct therapy? So this is the CLGB 80803 study looking at early PET saying, okay, for the patients who do not respond early on their PET scans, can we then change their treatment to give them a better chance at responding and do it quickly rather than just letting the disease take its natural course? This is an example of a Pi3 kinase inhibitor. So we know that Pi3 kinase inhibitors directly affect glucose uptake for the tumors. So this is actually data that we use in the phase 1 studies to show that we're hitting target. Not necessarily that we're going to have anti-tumor effect, but if you hit target with the Pi3 kinase inhibitors, you should see a very quick decrease in PET uptake, and that's the way we use them in these studies. What about blood-based biomarkers? So we've seen most of this data through the anti-angiogenic therapies. And so this was data that was presented at GI ASCO as well as ASCO this past year, looking at beaming. Beaming standing for beads, emulsions, amplification, and magnetics. And so can we use a blood-based sample to replicate an actual tumor biopsy? And so what this does is you take a plasma sample and you take circulating tumor DNA out of the plasma sample and use PCR to actually detect certain mutations. And so this is a very busy slide. You need a microscope to see it. But what I wanted to show here was data that was presented at GI ASCO this year, looking at concordance between KRAS mutational status in archival tumor specimens versus tumor beaming specimens, and then tumor beaming specimens versus plasma beaming specimens. And you can see here, I can't even use this. Okay, in the middle graph here, the concordance between tumor beaming and the tumor archival status was about 89%, and the tumor beaming versus plasma beaming was about 76%. So there was some good concordance there, but also makes one wonder is if with time do we catch more mutations within the plasma sample of the circulating tumor DNA than we do in patients with tumor biopsies. So in fact, are we catching more KRAS mutant patients looking at blood plasma samples versus historical tumor controls? And then we can also see here, we saw some concordance between Pi3 kinase status as well with tumor and plasma beaming. So an initial look into where could we potentially go using this as a surrogate for fresh tumor biopsy. A lot of questions still remain, and I think that there's studies that do need to be done looking at fresh biopsy compared with fresh plasma beaming. But can we also potentially overcome issues with tumor heterogeneity, where you might have a sampling error from where you stick that core needle into the tumor, where some sections may be mutated and some sections may not be? What about overcoming anti-angiogenic therapy resistance? So this is data that was done at MD Anderson, where they looked at patients treated with FOLFIRI plus bevacizumab and looked at certain tumors or certain cytokines within plasma and how they changed with treatment up to progression. And what we saw was there are a certain number of these cytokines that appeared to be increased upon progression. And are these signs that potentially we could hit these other cytokines or these pathways to make patients more susceptible to anti-angiogenic therapy? So this is one that came out of there. This is placental growth factor as a PD marker. We see the placental growth factor levels are consistently increased when you inhibit VEGF. And there's much more consistency between the assays. This is data from a trial looking at capecitabine, oxaliplatin, and bevacizumab, and the golden lines here are patients who had improved progression-free survivals compared to the median. And you can see here there's a trend towards patients with higher baseline placental growth factor levels having an improved response compared to those who had lower levels. So does that potentially help us predict who has an active VEGF pathway and who might respond best to anti-VEGF drugs? We've also used this to look at potential new targets in combination with anti-angiogenic therapy. So we also saw from this study that plasma HGF, hepatocyte growth factor levels, were increased about the time of resistance to bevacizumab potentially. And so could we hit the c-Met pathway, which is the HGF receptor pathway, in combination with bevacizumab to potentially have more anti-tumor effect? And so this is being looked at right now in metastatic colorectal cancer. This is a first-line study of FOLFOX bevacizumab plus or minus on artuzumab, which is an anti-Met antibody. So hopefully we'll see data from that later this year. What about toxicities as markers of anti-EGFR efficacy? So we've all seen this data that the worse rash that you get with anti-EGFR therapy, the better that you do in terms of progression-free survival as well as overall survival. And this has been taken in an initial randomized phase 2 study trying to bump the dose of the anti-EGFR antibody to dose to rash. And so for patients who have a grade 1 or less rash on treatment, they bump up the dose of cetuximab, and you can see here as you bump up the dose, there's a suggestion that you get an improved response. What about blood and tumor biomarkers? So this is one example where we're looking at them with the Pi3 kinase pathway. So this was a study of CC223 that was presented at ASCO both in 2012 and 2013. It's an mTORC1/2 inhibitor, and people are looking at this in terms of development for hepatocellular carcinomas as well as neuroendocrine carcinomas. And you can see the downstream targets including phospho-S6 as well as 4-EBP1. And within this study, they presented data looking at monocytes in circulating blood to show us that they're actually hitting the pathway. This is HCC and GBM patients looking at those circulating monocytes, seeing consistent decreases in phospho-AKT as well as 4-EBP1 with treatment with CC223. So we're hitting our target. And then if we hit the target strong, can that tell us who's going to respond and who's not? So this is one hepatocellular carcinoma patient who had a PR to treatment, as you can see on the CT scans. And this patient had a very consistent decrease in phospho-AKT within blood, phospho-S6, phospho-4-EBP1. Within the tumor. So can we start to develop these biomarkers again to predict who might have benefit from a certain therapy? This is also looking at PET scanning. As I mentioned before, hitting this pathway with these agents should decrease your SUV uptake because you're hitting the target, but we're also seeing some correlation potentially with CT decreases from baseline to also use this potentially to predict who might respond to agents hitting this pathway. This is also very beautiful work that was presented by Jordi Rodin at ESMO last year, looking at a Pi3 kinase inhibitor, BKM120. And here we see at the top graph, these are tumor biopsies that are done at baseline and then at cycle 2, day 1. And you can see consistent decreases in phospho-S6 and Ki67. But what's interesting is the lower right-hand graph is skin tumor biopsies and decreases in phospho-S6. So you can actually see that skin biopsies may correlate very nicely with tumor biopsies in showing on-target effects. So maybe we don't have to biopsy the tumor necessarily to show that we're hitting the target. And then the graph to the left actually looks at C-peptide levels. We've seen that, of course, Pi3 kinase inhibitors affect the glucose metabolism pathway. So as you are hitting that target, you will see an increase in C-peptide levels consistent with the hyperglycemia that we typically see with Pi3 kinase inhibitors, again, showing us that we're hitting the target well. What about the RAS-RAF-MEK pathway? So we've heard a lot of exciting data about targeting this pathway for patients with GI cancers, but this is a very interesting learning experience for us because we are now going to use PD markers to help us figure out how to best use these drugs for patients with colon cancer in particular. So this was data presented by Ryan Corcoran at ASCO this last year, looking at BRAF inhibitors for BRAF mutated colorectal cancer. So you can see from the top graph for mutant melanoma patients, you get this wonderful response to BRAF inhibitors. But when you look at the colorectal cancer BRAF mutated patients, not so much. They don't tend to do as well with BRAF inhibitors. So what makes colorectal cancer patients different from melanoma patients? Well, this is some very nice pharmacodynamic data, which gives us a way to look at it. So you can see here from these top gels, these are melanoma patients. So when those melanoma samples are treated with vemurafenib, you can see a significant decrease and a maintained decrease in phospho-ERK, which is downstream of the RAS-RAF-MEK pathway. But when you look at the colon cancer patients, so this is the second set of gels down, you can see here that phospho-ERK comes back. So for colon tumors as opposed to melanoma tumors, you still get that increase in phospho-ERK, so the pathway is still activated. So what is happening? So this gives us a thought to say, okay, well, maybe we need to hit both BRAF and then something downstream. So should we hit BRAF and MEK at the same time to more significantly decrease the phospho-ERK levels for patients with colon cancer? And so that's what they did in this study, where they used both dabrafenib as well as trametinib, so a BRAF inhibitor plus a MEK inhibitor for patients with colorectal cancer. And you can see here that it was much more efficacious than data with previous BRAF inhibitors alone. So we're making some steps forward based on biomarker data. Now, we can also see from this study that there was a significant reduction in phospho-ERK for post-dose biopsies in the patients on the study. So indeed, we're doing what we meant to do. We're hitting that pathway harder, and we're having more efficacy that way. Well, how do we move forward from here? Well, we're also seeing from preclinical as well as biomarker data that patients with increased EGFR expression seem to do better, seem to do worse than patients with lower EGFR expression. So is EGFR upregulation a potential mechanism of resistance that colorectal cancer cells use for BRAF inhibition? And we've seen data that suggests this preclinically, and so now the next set of trials is looking at combining anti-EGFR therapy with anti-BRAF therapy and anti-MEK therapy. So can we do even better for our patients based on this PD data that we've gotten? And here's another example of development of a phase 1 PD marker, so a PD marker that came out of phase 1 clinical trials and now has led into choosing that right patient population for phase 2 and phase 3 studies. Oh, I'm sorry. Okay, I'll be very quick. So this is looking at a patient with a gastric cancer that had, and we learned from the PD marker data from this study that that patient had high MET expression. And then we've seen consistently across multiple tumor types, this is non-small cell lung cancer, this is gastric cancer, and this is hepatocellular cancer, that this patient group with MET high status seems to benefit most from anti-MET therapy, and this has now been taken more into randomized phase 3 studies. And there's more to come. I'm going to skip through this one. And this is immunotherapy looking at PD-L1. We've all heard about this and how exciting it is, and we're seeing that patients who express high levels of PD-L1 for immunotherapy seem to do better in terms of benefit from anti-PD-L1 therapy. And we've seen this with GI tumors as well. And so what we're now seeing is that PD markers are becoming commonplace in drug development. They're helping us find new targets. They're helping us find subpopulations of patients who will benefit most. But what I really want to do is touch very quickly on this tumor heterogeneity, where you can see here, even within certain sections of the primary tumor, that you have different mutation status within the primary itself as well as metastases. And so what we have to start to think about here is how tumors are branching out and evolving as they progress and they obtain new mutations along the way. And so you can see this here in multiple different tumor types, a branched evolution of multiple different mutations, which we can then potentially learn how to target better. So are we going to look towards a future where we use PD markers to help figure out what these driver mutations are and then potentially longitudinally hit those particular targets along the way rather than combination therapy? So I think this is also a way that we're going to start to drive forward in terms of drug development for our tumors. Thank you very much.